and the Seattle Science Foundation, where we get to do a little deeper dive on some recently published manuscripts in the Journal of Neuro-Oncology related to tumor biology and tumor management. Today, we're delighted to have three authors with us today, Doctors Lo, Choi, and Wang from the University of Washington, UPMC, and Columbia, to discuss the Congress of Neurosurgical Congress of Neurosurgery guidelines on low-grade glioma and the utilization of radiotherapy. So with that, I'll let the authors take over. I'll remind the real-time participants that you can go ahead and type in any sort of questions that you have into the chat function, and we will try to get to them after the authors are done with their presentation. So with that, welcome.
Well, thanks so much for the invitation. Do you see my screen?
Yes, we do.
Okay. Yeah.
Just
so
sorry, we're seeing the presenter mode. If you could hit, there's a little caret to the top left. There's three different words. One of them is display settings, and there's a little caret to the right. Yeah, click that and then swap screen. Perfect. That looks great. Thank you.
So today I'm going to provide a brief summary of the Congress of Neurological Surgeons Systematic Review and evidence-based guidelines for the role of radiotherapy in the management of patients with diffuse low-grade glioma in adults, and is an update. So today, I will go over the summary of the guidelines first, and then this will be followed by Dr. Tony Wang, who will discuss about a paper that was a crucial paper that was published after the cutoff date for the search for this guideline. And then Choi would talk about the most up-to-date WHO classification system, which was published actually after the cutoff date, for this guideline. So these are the panel members. So my disclosure, Dr. Wang's disclosure, and Dr. Choi's disclosure. So back in 2015, the Congress of Neurological Surgeons published the initial version of the guideline for the role of radiotherapy in the management of patients with diffuse low-grade glioma. So the three key questions were what is the optimal role of external beam radiation therapy in the management of adult patients with newly diagnosed low-grade glioma in terms of improving outcomes, and which radiation strategies improve outcomes compared to standard external beam radiation therapy in the initial management of low-grade glioma in adults. And the third question is, do specific factors identify subgroups of better outcomes following radiotherapy than the general population of adults with a newly diagnosed low-grade glioma? So these are the recommendations. So because this was the first guideline, so a lot of the literature included was based on really old papers without without the molecular markers and things like that. So for the recommendations, there's a level 1 evidence to level 1 recommendation. Level 1 evidence to show that radiation therapy is recommended for newly diagnosed low-grade glioma in adults to prolong a PFS, irrespective of extent of resection, and then is recommended for patients with a low-grade glioma in adults as an equivalent alternative to observation in preserving cognitive function, and recommended in the management of newly diagnosed low-grade glioma in adults to improve seizure control and to prolong overall survival in patients with subtotal resection. And but the level of evidence is relatively low, it's a level 3. And for strategies, so delaying radiation therapy until recurrence or progression is recommended as an equivalent alternative to immediate post-op radiation in newly diagnosed low-grade glioma that may result in shorter time to progression. And addition of chemotherapy to radiation therapy is not recommended. So later on, after the publication of this guideline, CNS issued like a supplemental, like a letter to update the data in terms of chemotherapy. And limited field radiation therapy is recommended over whole brain radiation And either SRS or brachytherapy are recommended as acceptable alternatives to external beam radiation therapy in selected patients. And for prognostic factors, a level 2 evidence show that the age older than 40, astrocytic cytology, diameter greater than 6 cm, tumor crossing midline, and preoperative neurologic deficit. Those are negative prognostic indicators when predicting overall survival. And this level 2 evidence show that it is recommended that smaller tumor size, extent of surgical resection, and higher, a better extent of surgical resection and higher minimated state exam, they were considered as positive prognostic factors when predicting overall survival and progression-free survival. And there's a level 3 evidence to show that it is recommended that seizures at presentation and presence of oligodendroglioma component and 1p19q deletion were positive prognostic indicators. And finally, it's recommended that this level 3 evidence that increasing age, decreasing performance status, decreasing cognition, and presence of astrocytic histological component be considered as negative prognostic factors. So there was an update issued shortly after the publication of this guideline, because based on the RTOG 9802, which show that adding chemotherapy actually did improve survival significantly. So patients with oligodendroglioma younger than 35, those that had undergone more complete resection, had significantly better 10-year overall survival and progression-free survival when treated with the combination. And IDH mutation was the positive prognostic factor. And this is a high-level evidence. So it is recommended that chemotherapy be added to radiation therapy with newly diagnosed low-grade glioma who are regarded as high risk. So for this update, because basically this was building on the previous guidelines, because it was determined that since the publication of that study, actually it was started in 2020. So in those 5 years, from 2015 to 2013 to 2020, there weren't actually too much updates in terms of that would guide recommendations for management of diffuse low-grade glioma in terms of radiation therapy. So we did the PubMed search, January 1st, 2013 through January 31st, 2020, and we did a search based on PubMed and Embase. So we utilized the help of the University of Washington Medical Library. The librarian, did help with the search. And peer-reviewed publications within that date range, clinical studies in adult patients with newly diagnosed low-grade glioma, and clinical studies in adult patients with mixed, new, and recurrent progressive low-grade glioma were included. Only if data for patients with newly diagnosed low-grade glioma could be separated. And each study reporting on at least 5 subjects and adult patients, 18 years old or older, and publications only in English. So so we excluded the laboratory studies and studies where data from high-grade gliomas could not be separated from grade 2 tumors, and studies where data from pediatric cases could not be separated from adult cases. So this is the Prisma diagram. So we have identified 545 publications on PubMed and 567 on Embase, and the records were some of the papers were removed after duplicates were removed. So then we got 402, and then we screened all those papers, and we excluded 335. And then when we looked at the full text for eligibility, so we excluded another 60 papers, and so the finally there were only 7 papers included for the evidence tables. So question number 1. The pickle question 1 is in adult patients with pathology confirming WHO grade 2 diffuse glioma, is proton therapy superior to standard radiation therapy result in terms of overall survival, progression-free survival, local control complications, and neurocognitive preservation and quality of life? So out of the 67 studies eligible, there were only 4 that fulfill our criteria, and none of the studies directly compare proton therapy with standard radiotherapy. And 3 of the 4 were written in relation to one series of patients with low-grade gliomas assessed for proton therapies. effect on neurocognition, neuroendocrine status, and quality of life. And the fourth study was a retrospective series examining the incidence of post-treatment related effects and pseudoprogression in proton therapy with versus without concurrent temozolomide. So the recommendation is based on all the information available. There's insufficient evidence to provide guidance on superiority or inferiority of proton radiation effect compared to standard radiotherapy and WHO grade 2 diffuse glioma in terms of overall survival, progression-free survival, local control, complications, neurocognition, and quality of life. And pickle question 2 is in adult patients with pathology confirming WHO grade 2 diffuse glioma receiving radiotherapy to the molecular studies, molecular markers, IDH status, MGMT promoter, methylation status, and 1p19q presence or absence result in better prediction of overall survival, progression-free survival, local control, complications, neurocognitive preservation, and quality of life. So after evaluating all 402 studies that fulfill the criteria, 67 manuscripts were obtained for full text review, and 3 of the studies contained purely WHO grade 2 diffuse gliomas with molecular marker analysis with all the patients receiving radiation therapy, and all provided class 3 data. And it was suggested that 1p19q deletion status be used as a positive prognostic indicator regarding the effect of radiation therapy on progression-free survival and overall survival for WHO grade 2 diffuse gliomas. So one thing I want to add is, it is not addressed in this update, but as I've mentioned before, after the publication of the initial guideline, CNS issued a supplemental letter mentioning about that study, the preliminary analysis of RTOG 9802. And in that study, actually, IDH mutation was regarded as one of the positive prognostic factors. So we did not, because that was published already, so we did not include that study. So Dr. Choi, I can navigate the slides for you. Actually, Dr. Wang, I can navigate the slides for you. You can discuss about, this study that was published actually after the cutoff date for this guideline.
Certainly, thank you. So I'll be discussing post-hoc molecular analysis from NRG Oncology RTOG 9802, which is a randomized trial in low-grade gliomas. And as many in the audience may know, RTOG 9802 was the first randomized study to show a survival benefit for adjuvant PCV chemotherapy following radiotherapy in patients with high-risk WHO grade 2 gliomas. And as noted in the bottom part of the slide, at the time the trial was conducted, gliomas were not yet classified by their IDH mutations or by 1p19q co-deletion status, which we now know are key molecular determinants of both prognosis and treatment response. So this post-hoc analysis applied to the modern WHO molecular criteria to tumor samples, the 3 subtypes. So these are IDH mutant or co-deleted 1p19q, or IDH mutant non-co-deleted 1p19q, and then lastly the IDH wild type, which typically have a worse prognosis. So as shown in this slide, the addition of the PCV was associated with significantly long PFS, progression-free survival, and overall survival in both the IDH mutant groups, in contrast to IDH wild type tumors. And in this figure, let's just kind of look at the data. So in panels A and B in the top left, what we see here are the IDH mutant co-deleted subgroup. Here, adding PCV led to a remarkable improvement. The median overall survival, as shown in figure or 4A, was 13.9 years with RT alone, but not reached with the combination of RT and PCV. And then for progression-free survival in B, it improved from 5.8 years to not reached. So the hazard ratios were striking. It was 0.21 for the overall survival and 0.13 for PFS. And then moving to panel C and D, so this is the IDH mutant non-co-deleted cohorts. This group also benefits substantially with PCV. So the median OS, overall survival, improved from about 4 years to about 11.4 years with the addition of PCV, with a hazard ratio of 0.38. And likewise, the PFS also improved from 3 years to 10.4 years with the addition of PCV. And then finally, in the panel E and F, so these are the IDH wild type subgroups, and there was no observed survival benefit with the addition of PCV, and the median overall survival is about 1.9 years, um, regardless of the treatment arms. So these outcomes are similar to what we see in glioblastomas, highlighting the IDH wild type low-grade gliomas may essentially represent biologically aggressive glioblastomas that don't respond to standard low-grade glioma therapy. So just to summarize about this study, provides evidence that the IDH mutation status not only defines the prognosis, but also predicts benefit from adjuvant PCV. And with that, I guess for the next slide, Dr. Choi will talk about the WHO criteria.
Thank you, Dr. Wang. So yes, I want to go through the 2021 WHO classification of tumors of the central nervous system. This was the 5th edition that was published, and importantly, published after the search cutoff criteria for the low-grade glioma guidelines. So very important to think about and recognize when reinterpreting some of the low-grade studies, the older studies that helped provide data for the guidelines. So importantly, this was the 5th edition. Recall that in 2016, with the 4th edition, there was a major paradigm shift where molecular classification was brought into how we define gliomas. It's not based on histology alone. And so with this 5th edition, molecular classification comes into the forefront. And with this, there's 3 tumor types that are defined: astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19q co-deleted, and glioblastoma IDH wild type. Next slide, please. And so just describing how this classification is done, again, molecular characteristics are really coming into the forefront, the most critical one being isocitrate dehydrogenase, or IDH mutation status. And so with when you have an adult type diffuse glioma, you check for IDH mutation status, and if mutant, there could be 2 lineages: oligodendroglioma, which is defined by 1p19q co-deletion and TERT promoter mutation, or astrocytoma, which is defined by 1p19q intact and ATRX loss. In the cases where there is wild type IDH, typically what's found here are additional aggressive molecular features such as TERT promoter mutation, EGFR amplification, or concomitant whole chromosome 7 gain and 10 loss, which really define a glioblastoma here in this setting. Next slide, please. But important in this edition is really what you're seeing is molecular markers can really supersede the requirement of histologic criteria. And this is best illustrated in how astrocytomas IDH mutants are graded. They can be a grade 2, grade 3. And in the instance where you might find a molecular alteration of a CDKN2AB homozygous deletion, regardless of how it looks histologically, that would bump up the grade to a WHO grade 4. So a lot of important changes that had happened with the 5th edition, but very important in how we reinterpret the low-grade studies.
So the take-home point, there is insufficient evidence to provide guidance on the superiority or inferiority of proton radiation effect compared to standard radiotherapy on WHO grade 2 diffuse glioma in terms of outcomes. And 1p19q deletion status is a positive prognostic indicator, based on level 3 evidence. So after the cutoff data for the search for this guideline update, there are 2 important studies that were published that actually completely reshuffle everything. So R2G9802 genomic study identified IDH mutation and 1p19q co-deletion as positive prognostic factors. And recent WHO classification incorporates molecular markers including IDH mutation, CDKN2AB, and 1p19q co-deletion, which affect prognosis and therefore treatment recommendations. So in other words, in the olden days, you have like a grade 2 WHO grade 2 tumor. If it's like WHO grade 2 astrocytoma of IDH wild type, behaves like a higher grade tumor. Versus if you have like, nowadays based on molecular markers, a grade 3 oligodendroglioma with one P19Q deletion and one IDH mutation, behaves, somewhere between, 2 and 3. So it's extremely confusing. So all the old data, that we have examined and things like that, when we interpret the results, based on this systematic analysis, and given the, the new information, from the WHO classification and the RTG study, I think we need to interpret that with a lot of caution.
Wonderful. Thank you all. For those of us that have gone through this process of taking a tremendous amount of data and sorting through the abstracts and then eventually the articles and answering the PICO questions, it is it's a Herculean effort, and I applaud you all for participating in it. But I want to ask you, it's not really an off-topic question, but really what stands out from a 50,000-foot view about this process was that, and this happens all the time, we miss studies, we miss important studies, and then we publish the guidelines, and then we're constantly chasing the guidelines for what we think is important. So I wanted to get your opinion, all of you, of where you think we could make this better. Is it moving to registry-based systems and publications of registries that are more living, breathing phenomenon? Because, if you go back to guidelines from 2016, they're a waste of time. I mean, there's no real data in this that's mature data on vorasidenib and treatment of low-grade gliomas and concurrent radiotherapy, correct? Because it wasn't available. And yet, I don't know many people that are coming through our clinics these days with low-grade gliomas that I do a resection on, that's a sizable resection, that aren't going to be trialed on vorasidenib and holding off radiotherapy. That's just our clinical practice. Not a lot of people are going on PCV, and yet if you go to the guidelines, obviously PCV works. It's great. But I think the field is changing so quickly. Is it that our guideline system is not agile enough to be able to keep up? And I'd like to get your opinions.
Yeah. So I think, for Congress of Neurological Surgeons, the methodology, according to Jeff Olson, the best, based on my understanding, is they strictly go by, the literature with basically zero expert opinions and things like that. So, in my mind, actually a combination, may be helpful. Because then you can incorporate, more up-to-date information in the guidelines.
So more like a working group would come up with.
Yeah. So we have done, guidelines in other topics, CNS and non-CNS. Many a time we do a combination. But for the CNS, the Congress of Neurological Surgeons methodology is purely based on literature with zero expert opinion. So yeah, I think, we have come due to the, due to the strict guidelines, we're unable to incorporate, the more, up-to-date information in the recommendations.
Yeah, I'll just throw in just a quick 2 cents from a journal standpoint. The volume of studies that are being published and the subgroup and the important distinctions as we trend towards more personalized approaches based upon molecular and genetic markers makes the analysis that much more difficult. I just checked now, but if you jump on PubMed and type in glioma and radiation therapy, we're averaging about 3 to 4 papers per day in 2024. Now, certainly not all those are the highest impact studies, as you've indicated, but the sheer amount of information that's coming out is considerable. And obviously the molecular and genetic stratification is something that we can't go back and redo through all these important studies. So, but I think you've demonstrated an incredible amount of effort and impact to advance the field, and a nimbleness to adapt where appropriate, new information into the thought processes about how we consider radiation therapy and its impact upon low-grade glioma. So I commend you for it. It's a tough task.
Yeah, and I think what Congress of Neurological Surgeons have been doing is, if there are some new studies that are really critical, actually, they will publish like a supplemental letter to the editor to, modify the recommendations based on the new information available. Look, like what I showed, like the RTOG 9802, the preliminary study. So to recommend, because in the olden days, chemotherapy is not recommended, but based on the new data, and right now chemotherapy is recommended, so it's exactly 180 degrees.
I think we have one question that was up here, and I think I'm going to rephrase it because it's basically inquiring about the role, if there was any evidence about the role of focused ultrasound in any of the data. And once again, just from my own understanding of the literature, is that it's just not mature enough, and we don't have a lot of data that's published so far on blood-brain barrier disruption. Did you guys come across? I don't think there was anything probably in these guidelines, because the PICO questions really just were looking at radiotherapy, correct?
Yeah. So actually, for the CNS guidelines on low-grade glioma, I think Dr. Olson separated into different like guidelines based on the treatment itself, like surgery, like systemic therapy, and
Yeah.
the imaging guidelines, for CNS
Maybe
for
that'll come
low-grade
out.
glioma. So I think
that'll-
this is outside of the radiation therapy guidelines.
Yeah, maybe that'll come up in the emerging technologies guidelines as we see those.
So I want to
develop.
supplement one thing. So there's a study that has been closed, the RTOG NRG BN 005. I think it has been closed, and we're waiting for the results. So this study actually would answer, PICO question 1, comparing protons versus photons for diffuse low-grade glioma. In this study, actually, they included grade 2 and grade 3, but has to be IDH mutated. So hopefully, they in this study, they also track the neurocognitive function. So I hope the results of this study will be able to provide us with some answers. Dr. Wang, do you have any updates regarding this study?
No, I know it's close to accrual, but I imagine it's going to be some time before the results are presented.
And I can imagine if overall survival is wrapped into that as well as an endpoint, even if it's secondary for low-grade gliomas, we may be waiting some time for them to reach that final endpoint just based on the nature of the disease. Well, I have to tell you, this is a great effort. We're so pleased to have this in the journal. And on behalf of Dr. Sheehan and then the rest of our crew here for Tumor Talk, I thank you all. Jason, you want to wrap up?
Yeah, thanks again. Incredible key opinion leaders joining us today. Thanks so much for joining in the tremendous Herculean efforts to put these guidelines together. Looking forward to more updates. And if the CNS Guidelines Committee has updates, please reach out to us. Let's get them out to our readership through the Journal of Neuro-Oncology. Thanks so much for joining, and look forward to having you back with more updates.
Thank you for having us.
Thank you.
Pleasure. Have a good rest of the day. And for those who are interested, this will be archived on the Seattle Science Foundation Journal of Neuro-Oncology YouTube channel as well. Thank you now. Bye-bye.